welcome to the Future of Psychedelic Science, an online panel with Drug Science's Student Society Network. Today, we're joined by three PhD students at Imperial College London's Centre for Psychedelic Research, Sorcha O'Connor, Hannah Douglas, and Rayyan Zafar. All three are currently conducting research related to the possible therapeutic applications of psychedelics, such as psilocybin. Sorcha is currently leading the SAL-OCD study, looking at using psychedelic-assisted psychotherapy for OCD. Rayyan's work relates to gambling disorder, where he studies deficits in the reward system using neuroimaging, as well as the potential use of psychedelics in the treatment of addiction. Hannah is working as a trial coordinator for the study, investigating the use of psilocybin for anorexia. My name is Ben Clayden, and I'm the co-chair of the Drug Science Student Society Network. I'm also a student at the University of York, studying for an integrated master's in natural sciences, specialising in neuroscience. I'd like to welcome all the panellists for this evening. Thank you guys so much for being here.
Thanks
Lovely.
for having us.
Thank you very much. We'll first learn a little bit about our panellists and their work before delving into some conversations related to the future of psychedelic research. Could it become a frontline treatment for various mood disorders? What possible complications stand in its way? And what may the scene look like in 20 years' time? These and more to be answered shortly. So let's begin. Sorcha, are you able to introduce yourself and talk to us a little bit about what OCD is?
Yeah, of course. So to introduce myself, I'm a second-year PhD student, and I'm coordinating the SAL-OCD trial, which is looking into the potential benefits of a low to moderate dose of psilocybin in treating OCD. And we're giving quite a low dose. I can say the dose that's being explored, it's 10 milligrams. I can't talk about the dosing sequence or anything like that, so I'll be careful with that. But yeah, essentially we're looking at this dose because, we're looking at this potential treatment because OCD is such a notoriously difficult psychiatric condition to treat. And in essence, what it is an unwillingness to tolerate uncertainty around one or more themes. And stereotypically, or people associate OCD with either its contamination presentation, as we can call it, which is an irrational fear of falling ill, of poisoning yourself, of accidentally contaminating other people's food, can really vary around those ideas, but it's that those are the principles, and most people associate OCD with, washing their hands and those types of compulsions. And another stereotypic presentation is what we call just right OCD, which is the discomfort around things not being just right and a need to rearrange things or redo things to get the just right feeling. There are really so many other potential themes. Someone can suffer from any form of OCD under the sun, really, because there are always core fears at play and outcomes that individuals want to avoid, which they conduct rituals to try and avoid. And interestingly, rituals can also be very much avoidance-based, which is something that isn't always spoken about. So you can have people who, count down from 10 in their head and try and distract themselves from their thoughts, or you can just have someone who worries about an outcome happening and who doesn't want to leave their house. So you have a lot of comorbidities like agoraphobia, other anxiety conditions, generalized anxiety disorder. Secondary depression is really, really common. And if I'm going off on a tangent, let me know. But in terms of treatment, the gold standard is really psychotherapy, exposure response prevention, which entails just targeting the core fears that drive an individual's OCD. But this is very tough to do. So pharmacotherapy is also used, and SSRIs are pretty much the main family of drug that are given. And you can have adjunctive medication too. But we see between maybe 40 and 60% improvement on average. So unfortunately, a lot of patients are treatment resistant, which really reveals the need for a paradigm shift in how it's treated and potentially how we view it as well. So yeah, that's OCD.
Thank you very much. And I suppose related to that, are you able to tell us a little bit about the work that you're doing, as well as how psychedelic-assisted therapies may be beneficial in the treatment of this disorder?
Yeah, so SAL-OCD is very unique because we're not just looking at potential therapeutic improvements in symptoms, we're also looking at how psilocybin might improve features of cognition that we know to be deficient in OCD. Because interestingly, we now don't just view OCD as an anxiety spectrum condition. It's now placed in a family of disorders called obsessive compulsive related disorders. in the DSM-5, and this recent shift was initiated around 10 years ago when research into things that might precede OCD took off, because we now know that there are certain deficits that we also see in unaffected relatives, potential endophenotypic issues related to things like attention, decision-making. For example, OCD patients are particularly bad at something called set shifting, which is the ability to shift from one dimension of a stimulus to another dimension, but they're not bad at learning rules. So it's not anything to do with intelligence, it's just the ability to shift attention. So we're looking at this within our trial as one of the primary outcomes. We're also looking at other things like decision-making, and in terms of neuroimaging, we're employing EEG to look at neuroplasticity and quantify it using a novel paradigm that hasn't really been explored in the context of OCD or similar conditions. And beyond that, we're also looking at a lot of different effective measures. So just general well-being, general mood-related measures along the 2-month period that participants are tracked for. But yeah, sorry, to give a bit of information into the actual design of the study, there are 2 dosing days and they're 1 month apart. So participants have prep sessions beforehand with 2 therapists that they're allocated who have a lot of experience in psychedelic guiding and psychedelic trials, typically psychiatric related trials. And then they have the first dosing session, then they have integration sessions, and then cognitive tests and all these questionnaires that they do. And the EEG is done on the 2 dosing days and also on the screening day, which is the baseline. And a final outcome I don't think I've mentioned is we're also looking into blood. So we take bloods before and after each dosing session to look at essentially how psilocybin might be impacting the immune system, looking at certain inflammatory mediators like interleukins, also cortisol, so just other molecules, hormones involved in the stress response, to see how, to look at the micro level a bit as well and see if there's the shift between the 2 dosing days and whether that correlates with any other improvements that we see.
That sounds utterly fascinating, Sorcha. Thank you so much. I suppose we can move on to Rayyan now. So, Rayyan, are you able to introduce yourself a little bit and tell us about the work that you do at the centre?
Cool. Yeah. Hi everyone. I'm Rayyan Zafar, and I'm recently finished my PhD. So I've handed in my thesis a month ago. I worked at Imperial for the last 4 years, and also at Drug Science as an honorary research assistant, and then kind of rose up doing different research and became a senior researcher. I've worked in both those fields, but at Imperial, I guess for the last 4 years, my main work has been revolved around exploring the underlying mechanism of action of addiction. So addiction is a disorder which affects around 150 million people globally. And it's actually an ever increasing disorder with very limited number of effective treatments. Actually, out of all of the mental health disorders, addiction has the highest treatment gap. So in addiction, less than 10% of patients actually receive a treatment, specialist treatment, be that talking therapy or pharmacological therapy. And that's for several reasons. And I guess we can go on to that in a bit. But I guess to begin with, my core research I did with my PhD was exploring the neuroscience that is behind some of the pathology that we see in addiction. And that's kind of centered around the system called the dopamine system in the brain. So if you talk about psychedelics, everyone talks about serotonin a lot. We talk about addiction and kind of wanting, that's kind of a more dopaminergic function. And people talk about dopamine as a molecule of more. And so my work at Imperial was actually trying to understand the role of dopamine across addictions. That was one of the studies I did. And we found that dopamine actually wasn't this kind of, sole biomarker or sole neurotransmitter, which was causative in addiction. And actually, it's a much more complex disorder involving lots of neurotransmitter systems. And then a second part of my PhD was actually trying to explore the neurobiology of gambling disorder, which is a behavioral addiction. And behavioral addictions haven't really seen as much press in terms of the medical world or scientific literature. And so In recent years, as it's become more of a clinical problem and gambling addiction has been recognized only in 2013 as a medical condition, scientists and medics are more keen to understand, are there any kind of biomarkers in the brain that we can look at to distinguish someone with a gambling disorder? And with that information, might that be, a doorway into developing more effective treatments? So that's essentially been the kind of essence of my work. And quite excitingly, in the last year, we were successful in winning a grant to actually now use some of that neuroscience research and see whether psychedelics hit the brain targets that we think are responsible for gambling addiction. And also we'll be running a trial in heroin addiction as well with psilocybin therapy. So yeah, lots going on and lots to do still.
Yeah, and it sounds really, really awesome. Yeah, and I wanted to ask, what is the rationale behind trying to use psychedelics in the treatment of addiction?
Yeah, so the kind of history of psychedelics treat addiction in the Western world goes back over 100 years, actually to the founder of Alcoholics Anonymous, a guy called Bill Wilson, who actually took this. So he didn't actually take a psychedelic to begin with. In 1933, he went to New York State Hospital and took a botanical mixture which contained several plants which caused delirium. And these were belladonna and henbane, which are slightly different psychedelics, but they induce this kind of state of extraordinary levels of consciousness and a white, bright light. And then he went on to take LSD and actually encouraged the NIH in America, so National Institutes of Health, to run 6 clinical trials with patients with alcohol addiction. And Bill Wilson's work and the work of others in the first wave of research found that LSD for alcohol addiction was 2 times more effective at reducing heavy drinking days and maintaining abstinence at 6 months than placebo. So at that time, that was around 2 to 3 times better than any of the pharmaceutical treatments that we currently have available for alcohol addiction. So a lot of that historical research catalyzed some modern day research done at Johns Hopkins University with nicotine addiction and New York University with alcohol addiction. And again, repeating similar findings in that psilocybin this time was around 2 to 3 times more effective than current available treatments for both alcohol addiction and smoking addiction. And so there's a wealth of clinical research, a wealth of real world research, people going to the jungle or to ceremonial retreats in South America. There's lots of new different kinds of non-classic psychedelics, which are now showing to be effective in treating addictions. That's ibogaine is one example from Africa, MDMA for alcoholism, ketamine as well. And so I'd say after depression, the kind of bulk of clinical research that we're seeing at the moment in terms of the most advanced clinical trials right now have been addiction because they've finished their phase 2 and they're starting what we call phase 3, which is the regulatory trials. And so we thought there's a lot of work going on in substance use, but there doesn't seem to be that much in the way of behavioral addictions. And as I said before, only about 10% of people with a drug addiction receive treatment. Actually, people with gambling addiction, only 3% of people with a gambling addiction receive any treatment. And so the numbers are much lower, and there's a significant proportion. I think YouGov estimated 1.4 million people in the UK with a problem gambling. So there's a significant majority of our population that could possibly do with having a treatment. And right now, there are no licensed pharmacological interventions for that group. So a combination of the historical past of psychedelics being effective for addiction and the lack of innovation for behavioral addictions kind of motivated us. So that's myself, Professor David Nutt, Dr. David Aritza, and Dr. Matt Wall, who are the study team for this, to apply for a grant to study psilocybin therapy in the treatment of gambling disorder. And yeah, I guess we will wait for the data to speak for itself. But if I was to hedge a bet, which is probably not the best term to use, but I'd say we probably will see some clinical effects. But a year from now, We'll see.
Fantastic. It sounds really, really interesting, and I wish you all the best of luck with that. And last but certainly not least, Hannah, are you able to introduce yourself a little bit and also tell us about anorexia and why it's particularly difficult to treat?
Oh, he's gone. Yeah, of course. So I'm Hannah Douglas. I'm currently a final year PhD student. So over the last 3 and a bit years, I've been coordinating a study over at the Centre for Psychedelic Research based at Imperial College London, investigating psilocybin-assisted therapy for the treatment of anorexia nervosa. So psilocybin being the active component of magic mushrooms. So that's the classic psychedelic that we've chosen to work with. And I suppose just to give an overview of what anorexia nervosa is, so some of you might not be aware. Unfortunately, some of you might know somebody that struggles with this condition because it is quite common, especially in young adolescents. But it's a debilitating eating disorder that's characterized by, firstly, restriction of energy intake, so restriction of food intake that leads to a body weight that's classified as below the minimum of what you would class as a healthy BMI. Fear of weight gain and the behaviors that go alongside that to reduce the weight gain. So again, reduction of energy intake, but also over exercising is often seen in this population. Finally, there's also denial of how serious this condition is. So you see this really often, that people who have the condition actually won't admit that they have a condition, and it might not really be intentional. They're just consciously not aware that they have the condition. If they are, they might be in denial about how bad it actually is and how low their body weight is. And there's also how they kind of experience their body and themselves as people. So when they evaluate themselves as people, so when they think, how valuable am I as a person, they take into consideration their weight and shape far too much, and see it as quite important in who they are as people. And I suppose it's such a devastating disorder because the onset age is usually between 15 and 19 years old, which is obviously really young. And the recovery rates aren't great. So around 20% of those will go on to make a full recovery in a lifetime, and around 20 to 30% of those will also have it for kind of a lifelong condition, definitely chronically. And this just speaks to kind of the current treatment options and why they're not working for most people, I would say. So the current treatments tend to be, especially for young adults, so if it's caught within the first 3 years of the condition developing, the recovery is much more likely. But once it progresses past this 3-year point, recovery is far less likely. But with adolescents, it tends to involve a lot of family work, but this doesn't appear to be as helpful in adults. And a lot of the work that's done in adults is more to do with weight restoration, so encouraging weight gain, which can be in itself quite damaging, I think, for the patients that go through this. And a lot of work with kind of reconnecting with your body and trying to understand the condition. But I think that these treatments don't really tend to delve too deeply into what is actually underlying the condition. And once somebody is actually weight restored, they tend to be released from the care. And a lot of these people do then tend to relapse. And actually the people that eventually get into treatment, unfortunately, around 50% of those do discharge themselves anyway. So we're not seeing too much of a positive impact at the moment, I suppose, with the existing treatments that are available to people. So I suppose this is why it's important to be looking at other avenues, especially when the people that suffer with this condition are so young usually, and with such a high percentage of those going on to live with the condition. It does also have the highest mortality rate of all psychiatric conditions, and I'm not sure if that's something that's that well publicized, but it isn't an addiction. It's actually anorexia. So around 10% of those that develop anorexia will unfortunately die from the condition, and around 25% of those will die as a result of suicide. So again, really just reiterating why it's so important that we are investing in different areas of research, and particularly novel areas of research that we think have the potential to help people, which is why we're conducting the study that we're currently conducting.
Oh, it sounds like an immensely important cause and study. I just wanted to ask, so obviously it's very important that we're looking for new novel possible therapeutic interventions, but why psychedelics and how might they be helpful in the treatment of anorexia?
Yeah, so I suppose at the moment, there's not really a consensus on what is underlying anorexia specifically. I think generally it's thought that there's a genetic predisposition that could be triggered by things like the environment or personality factors such as low cognitive flexibility or obsessionality. So it's hard to know what exactly the psychedelic assisted therapy is working on because we don't have a great model of what causes anorexia. But I suppose if we think about the previous work that's been done with psychedelics and what we've seen with other conditions, we can start to build an idea of why it could potentially be helpful for people with anorexia. And I think people with anorexia, quite similarly to what Sorcha was saying about people with OCD, there's a lot of rigidity in terms of the thought patterns and behaviors, particularly relating to the weight and the shape. And these can become really, really ingrained and really difficult to change, especially over the years that they become more a part of their lives, and especially with the resistance that we see to treatment as well. So there's not a lot of motivation to actually work on this either. So the people that are treating them are really kind of up against a brick wall sometimes. So what we've seen previously with other conditions with psychedelic assisted therapy is the potential of these compounds and the therapy that goes alongside it to actually open up this window of opportunity for people to see things differently, to break down these rigid thought patterns. There's a lot of work and papers on this, the rebus theory that comes from one of our supervisors, about really breaking down those beliefs that people have about themselves are so ingrained that they're not really going to be able to be changed in normal therapy, I suppose. And with the addition of these psychedelic compounds, it really allows people to potentially engage in this therapy in a different way after having a different perspective on things that they maybe wouldn't usually have. And there's also, I suppose, just kind of basic theories related to how psychedelics work. So the serotonergic mechanisms that psilocybin potentially, or it has by binding to the serotonin 2A receptor. Anorexia is also thought to have serotonergic dysregulation that relates to the mood and the impulse control that we see difficulties with in this population. And a lot of people that have anorexia actually also have comorbid conditions. So around 70% of those will also have anxiety and depression. And we already know that psychedelics can help with depression. There's a lot of research on that. And there's also indications that it could potentially help with anxiety. And as Sorcha is doing work with OCD as well, this is really common in people with anorexia as well. So even just those general improvements in the quality of life, improvements in those comorbid conditions, can also be really beneficial to people with this condition.
Thank you very much for that wonderful explanation, Hannah. And it's very clear that you guys are all doing some incredibly important and very, very interesting research. So at this point, I think we'll open it up to a little bit more of a panel discussion. And the first question I wanted to ask was, what are some of the biggest unanswered questions right now which may determine the future of psychedelics as therapeutic agents?
Who's going first?
I don't know, you unmuted, so
Whoever fancies, I suppose we can just do, shout out if you've got something, whoever fancies it, yeah.
I personally think the biggest unanswered question right now, the most exciting one, is can we personalize dosing and delivery of treatment to optimize outcome for patients? And how do we do that? So we know that many patients with psychiatric disorders present in different ways. We know that diagnoses in and of themselves are very broad in general. One person with an addiction may not look the same to another, or one person with depression may not. And so is there a way that we can understand, maybe through biomarkers or maybe multimodal kind of systems where we do behavioral tests, biomarkers, etc., start phenotyping patients and say this person may be more suited to DMT or more suited to psilocybin or more suited to ketamine. And then after that, what the dose is. Do they need more? Do they need less? I think that's sort of a lot of the research we're doing. We're trying to move towards that precision psychiatry, personalized medicine approach.
Yeah, it sounds immensely interesting, yeah.
I was just going to add to that, I suppose, that maybe from outside of our work, it looks like we're kind of have an idea of what the model should look like. There's preparation, so preparing for the experience, actually having the dosing experience, and then having the integration after, which is where you come back and kind of talk about it and how to integrate what you learn into your life. But I think we're actually quite a way off having that model finalized, and especially if it was to ever be rolled out as part of the NHS or even in private care. These studies are so incredibly expensive that actually there's not a huge amount of them that have been done in different ways to test these different models. So how many preparation sessions do you need? What is the right number of dosing sessions? What's the period between dosing sessions? What dose do you need? Like Rayyan said, maybe that's more to do with personalizing for different people with different conditions. How much integration is needed? We generally know that more integration is needed than what is currently provided, especially in clinical trials. That's usually related to a lack of money and a lack of how long we're able to actually continue these studies for. But there's a lot of work that needs to be done on that. And I think we are a long way off from actually knowing specifically what the model is going to look like when it gets rolled out, and whether that's going to be different for different conditions. Maybe more people need more preparation than others, especially maybe those that have higher anxiety levels. And what is the integration going to look like? Who's this going to come from? Is it going to have to be the same therapist that were with you in the session, or can this be provided by other people in the community?
Yeah, this is really important because psychedelics do target so many different neurotransmitters, and all of these conditions that we're speaking about, as Rayyan and Hannah have also mentioned, they don't really, or alluded to, they don't really have clear biological fingerprints. Whilst we can isolate and identify certain brain loci that might be hyperactive in anorexia and gambling, and slightly less so, but still in OCD, we still see that. It's still, we don't really have unifying ways like litmus tests or litmus diagnostic tests for these conditions. And going back to the, optimizing psychedelic assisted therapy, we also, as Hannah mentioned, we also don't really have a model for that. So there are lots of different moving parts, and it doesn't feel like anything is optimal yet. But I think we're still doing the groundwork. And like my study, for example, we don't have OCD specific therapy, which I think is, it's just a feasibility study, and it's how it is. But I think, we'd need we need to explore different ways of doing ERP alongside, psilocybin administration, to actually figure out how a drug like psilocybin or other psychedelics might be used to, to streamline recovery. And I can imagine it being similar for other conditions, especially since others actually have more, potential psychotherapeutic techniques that work with, because OCD is quite unique in the sense that most types of CBT aren't actually that effective. But yeah, it's challenging, and you also get a lot of individual variation in just pharmacokinetics, drug metabolism, all these things that we don't really have the capacity to measure for. And yeah, even things like, whether participants or patients should be able to, in trials, should be able to be on antidepressant medication if they're if they're in a psilocybin trial for OCD. It's never really that clean cut, which is, I guess it's important just to have as many studies as possible at this stage and just compare and contrast data.
Brilliant. Thank you guys very much. And just as a quick one, because we did get a question about this, but you were talking about personalized medicine and also potentially personalizing the type of psychedelic. How come you guys focused your research on psilocybin as opposed to other compounds?
So I think so this is a repeat I've heard Robin and Dave Nutt say about this. So I think the bulk of the research that was done in the 60s and 70s was LSD. And with LSD came certain political connotations and a stigma associated with that compound. So that's one reason why psilocybin was chosen, because actually it was less well known. It's a chemical sounding product. And it might have been easier at that time in 2012 when they did their first research to kind of work with ethical boards. So it wasn't like they were trying to hide anything. It was very clear what the substance was, but it just didn't come with all of the kind of cultural and societal stigma that LSD had with it. And then I think the second thing is clinically, although at the time they didn't have so when they started this research, they didn't have a clinical focus. It was more brain imaging to understand the neural correlates. But now, looking back, it was maybe a clever move because the clinical effects of psilocybin is 6 hours, whereas LSD 12 hours. And so it's still, we know now that it still has an equal therapeutic effect. But in terms of translating that into a clinic later on, that will be more efficient in terms of an NHS, which is very under-resourced. And then, yeah, I mean, the rest, I mean, Hannah or Sorcha, you can talk about some of the other drugs that we do research with now, maybe.
Yeah, I mean, I was just going to add to, obviously, having run these trials myself, working with psilocybin alone, which obviously has a duration of action of 4 to 6 hours, having a patient in the room, they're with us the entirety of the day, and we have our guides or, you know, our psychiatrists and therapists with us for a really prolonged amount of time. If we were to actually introduce LSD into that equation, where the duration is 12 hours, it's really it's not really feasible to run clinical trials on our end anyway. Maybe more in companies it would be, just the time that it would require. And I think generally LSD is known to cause slightly more anxiety than psilocybin. So especially when you're working with these populations that already have quite high anxiety levels with OCD and anorexia, inducing something that could lead to even higher levels of anxiety when there's the alternative that's got a shorter duration of action and also causes less anxiety. Seems like the right option at the moment. I suppose, I don't know if Sorcha wants to talk about this potentially, but there's a lot of work at the moment moving towards DMT instead, which is much shorter acting.
Yeah, I mean, I'm probably not the best first person to speak about the DMT research because my background is very much neuroscience from a psychiatric perspective, and kind of bringing in psilocybin as one of many tools to potentially kind of unwind a vicious cycle like OCD. So I would not be the best person to go into depth about DMT because I haven't really worked with it.
We can maybe say a few words with that, or no, you if you want to carry on.
Yeah, I mean, currently I don't know if they're dosing, but I know we're starting a new DMT study that's focusing on synaptogenesis, and it'll be similar to a ketamine study that has just finished, which was on healthy controls, so different to all of our work. A small, I think around 20 participants as well. They were all male. I'm not sure why they were. I think that was just to keep it as homogenous as possible. And I believe they underwent EEG and PET, was it? I think.
Yeah, so it was to explore the question of whether ketamine can induce the growth of new synapses as a potential mechanism for its therapeutic effect. And as Sorcha said, now we're trying to see whether that's also the case with DMT. Because actually DMT, I think, has been shown to be the most, the psychedelic which has the greatest psychopastogen potential in preclinical research. And so we think maybe in the human brain that might be reflected by the increase in neurons and dendritic spines. But we can measure synaptic integrity. But yeah, the other one that we did mention was 5-MeO, the toad. And we are, well, it's not the toad, it's the toad in Mexico secretes it, but we're also doing some research. So our colleague, Tomaso Barber and Chris Timmerman are going to start a very exciting trial on that in the coming year. So watch this.
Yeah, I've just seen one of the questions in the Q&A about kind of maybe why we're not using DMT. I suppose, I mean, our team's actually doing a huge amount of work with DMT currently. I feel like we've become a DMT lab overnight. But I think in terms of clinical populations, a lot of the work that already exists is with psilocybin. That's where the evidence is based. And there's always been this worry that maybe the duration of action, the duration of the experience isn't long enough to actually have a therapeutic effect in the same way that psilocybin does. And I mean, a lot of people will say that obviously DMT is the most intense psychedelic experience that you can have. So there's also caution around that, I suppose. And now that the research has been done in healthy populations, and I know that obviously Small Pharma were doing work in depression, that maybe that's going to move more into clinical populations now that has been looked into a bit more.
Yeah, so I think actually Small Pharma did publish on their depression research and actually found pretty amazing results after, very short infusion, less than 30 minutes. And I think our lab was actually involved. So Dr. David Rizzo was the chief investigator. And I think DMT is now being explored for its role in addiction. So 5-MeO-DMT for alcohol addiction, 5-MeO-DMT for treatment-resistant depression, which Beckley Psytech are doing, and also Small Pharma, and which are now called Cybin, which is another company that they've merged with, are really taking forward DMT as the lead candidate. And I think it would be good to have all these options on the market for clinicians to use, because I guess, there are some kind of concerns over how long a trip is, but also, as we mentioned before, kind of efficiency is key worry in terms of having the cost of, a therapist and 6 hours in a room. It's not a model that the NHS is used to right now in mental health.
Brilliant. Thank you guys very, very much for that. So I wanted to move it back a little bit towards ideas of the future and what may happen in this scene. And I wanted to ask what technological advancements and types of studies may be needed to help facilitate the answering of some of these questions you raised about the future of psychedelics.
It's a very good question. There's so many ways we could tackle this. I mean, I think neuroimaging will be really important in potentially just further elucidating what actually drives all of these conditions, first of all. I think we need maybe a more coherent way of, or, maybe having subtypes of each condition. For example, OCD with a strong element of ADHD is very different to someone with OCD who is depressive and doesn't have much energy. I see even with my participants that are all very, very different, and they have different experiences and different ways of integrating what comes up in the psilocybin experience as well. So I think that's important. And I also think I think digital tools could really help. I think even things like, using AI to better understand patterns of speech and things like that, people journaling, maybe using apps for participants to use between dosing sessions where they, maybe record a voice note every few hours, or, type something, just a very raw couple of sentences about how they feel. And, there's an algorithm that determines, whether they're likely to be depressed, or, that just the better reports their improvements as well beyond just self-reported scales. And I have to shout out Joanna Cook, spelled Kuc, at UCL, who is doing her PhD there and working on a lot of computational things involving journaling and language. She's definitely made me think about all of this, because it's interesting that, language is the paradigm by which we communicate how we feel, and we're ultimately just talking about, feelings and how and emotions and, mental states here. So I think that kind of tool could potentially quantify improvements better. And I think, I'll let the others come up with some ideas as well.
Yeah. Do you want to go, Rayyan? I feel like you're the expert on this.
Wait, so the question was, what can we do to improve research?
Well, I suppose the question was related to what type of advancements would be needed, or what type of studies might be needed to answer some of these key questions determining the future of psychedelics.
Yeah, what I think we need to do that we haven't done so far is link so we know a lot about acute drug effects of psilocybin in healthy individuals. So we know that it causes these increases in functional connectivity, a reduction in the activity of certain regions of the brain, like the default mode network, and the disintegration of some of that, coupling of that network with different kind of functional networks in the brain. And then we also know in our latest study that Robin published last year with others, that after individuals with major depressive disorder take psilocybin therapy, there seems to be this kind of hangover effect of changes in the brain's functional circuits, which seems to correlate with treatment outcomes, such that patients essentially have increased connectivity in their brain, compared to before they started treatment. And the more increase you have in your connectivity, the greater your depression scores. Now, that's good to know. But what we don't know is why some people have a greater degree of change in functional connectivity. And is that related maybe to the acute change in their brain? So if we could do a study where we could do acute scanning of an fMRI in a patient, and then also a follow-up scan, we can link how the actual acute effects of the drug link to the long-term effects of the drug. And that essentially would be an end-to-end kind of neurological targeting of the therapeutic effect of psilocybin. And I think that as a clinical, that as a clinical research question is definitely an area that I think is worth exploring for sure.
Fantastic, thank you.
I suppose I would just maybe add on to what Sorcha said. I think you'll go on clinical trials at the moment at clinicaltrials.gov and see, so I mean, the number of conditions that are now being investigated in terms of psychedelic assisted therapy is, I mean, I think it's basically every psychiatric condition that exists. But I think before this could get rolled out, there's so much more that we need to learn about the conditions that we're already investigating. And I mean, I personally would love to see a lot more studies done in the conditions that there's already data existing for. Obviously looking at other conditions is important, but there is, we really, I mean, obviously with depression, there's a huge amount of data there now, and we're pretty confident that that is effective. But I think when you look at these conditions, like Sorcha was saying, like OCD, like anorexia, where there's a lot of intricacies, and I think we would need to do a huge amount more work looking at the different characteristics, who it would work for, who it wouldn't work for, even different eating disorders. How do these models need to be modified? I don't think we can just plop this one model for depression on top of all these different conditions and hope that it's going to work for them. So I think numerous studies trying different models, different arms of psychedelic assisted therapy, looking at the different models, the different conditions, really delving into what we can do to optimize this before we even get close to rolling it out.
Fantastic, thank you all so much. Some really, really valuable points there. I wanted to ask one more question before we open it up into the Q&A questions. And this is, I'd like to hear your guys' opinions. Can you see psychedelic assisted psychotherapies becoming a conventional treatment in the UK? And what may be the biggest problems that get in the way of that possibility?
Well, I think I would like to see that. I think we really have to, honestly, I think it will be interesting to see what happens over in America. I think historically we tend to follow whatever they do, so I think that'll have a lot of influence on us. I do think that we're further behind them. They seem to be more open to, obviously, I mean, I say we follow them, but then you've obviously seen what happens with cannabis over there, and we don't really seem to be following along. So I think there's a lot of politics involved as well that we have to take into consideration. But I think as the data builds, hopefully at some point, especially in terms of depression, which already exists, it will be hard to deny the positive effect that this could have on people with depression, and hopefully other conditions as we do more research. But I think we're likely to see this available in private clinics to start with, which is obviously something that we need to think about. Who is that accessible to? How much is that going to cost? How can we minimize this cost? How can we try and make this accessible to the people that need it? And then maybe much further in the future, something that could be available on the NHS. But I do think we'd be looking at private therapy or private companies initially.
Yeah, I kind of agree completely with Hannah, although Australia right now has legalized psilocybin.
Can't hear you.
Oh, sorry, can you hear me now?
Yeah, I can hear you now, yeah.
Okay, perfect. Australia have legalized psilocybin therapy for treatment-resistant depression currently, and MDMA-assisted therapy for post-traumatic stress disorder. And that's actually now available through psychiatrists in the legal kind of framework of medical prescribing. And I think that will be an interesting case example of how the UK may be able to translate the kind of clinical output into our own sort of public health systems. The key thing to think about is cost. And a recent piece of research that's come out of drug science and some of the collaborators was actually comparing the cost of depression treatment for a year versus psilocybin therapy. And what they found was that actually it's pretty comparable. So it costs about £7,000 a year to treat someone with daily SSRIs and CBT. But actually, when you look at a single psilocybin therapy session, which can have clinical effects up to 6 months and maybe beyond for some individuals, it's about 7 or 8,000, and it can go up to 14,000. But I think as more competitors hit the market, so more biotechs, if there isn't a monopoly, essentially, then costs will come down on the product. And when costs come down, NICE, which are the regulators that approve whether or not a medicine can be used in the NHS, if it goes within a certain bracket, so it's between 20 to 30,000 pounds a year they're allowed to spend on a patient. So if the full cost of the package comes below that 30,000 pound mark, then that's when we'll get the green light. And that's where we've had problems with ketamine assisted therapy in the NHS. So Spravato, which is intranasal esketamine, hasn't been licensed in the NHS as a treatment because of cost. But it is available privately. So cost will be a major issue, I think. And the American system, which favors kind of commercial private healthcare, will definitely see more patients reach it, I think, first, which is unfortunate unless we change the way that we fund medicines and psychiatry.
Yeah, this is tough, especially because I think one-off sessions are unlikely to be sufficient for a condition like OCD. I'm not sure about gambling and anorexia, but I suspect that the same would apply. I can see how maybe a single session would be effective for a specific phobia or something like that, or someone who's depressed and feels like it's quite a simple depression in the sense that they just need to gain more energy and just be able to realign with life. But I think when I think of my participants, I don't think any of them would be happy with just 1 or 2 therapy sessions. I think they'd all want a lot of integrations. But I mean, as Rayyan said, mentioning the costs, I think that could just fall into a similar territory that they're currently faced with if, they're engaging in CBT or ERP that isn't proving that effective because they feel blocked. So maybe it is feasible. Yeah, it's definitely tough. I think also, I mean, going back to what Hannah said as well about why we use, well, one of the reasons why we use psilocybin is it does involve between sort of 4 to 7 hours with therapists. But I think for something like OCD, it would be quite hard to sell the idea of DMT to most of them, and I think it would be too much for a lot of people with that condition, because a lot of them fear loss of control, and they ask a lot of questions around that before the psilocybin experience. So I think it is going to be a balance of how efficient it can be while remaining humanistic, like with that kind of humanistic approach of having enough integration sessions. And fortunately, it's very hard to predict.
Brilliant. Thank you guys all so much for your really valuable inputs. I'm going to do a couple questions from the audience. Apologies in advance if we don't have enough time to go through all of them. So first one is a question for Sorcha. How do we think psilocybin affects the immune system? Is it being studied as a potential mechanism of action or as a therapeutic side effect?
So this element of the study is actually a very minor outcome, unfortunately, because it's very interesting. But there isn't that much research into psilocybin on the immune system. There are a few papers here and there, I think mainly reviews just discussing how it might affect certain inflammatory mediators, essentially certain molecules that we know to be abnormally high in concentration in the blood when someone's in a state of chronic inflammation, as we call it, although that's quite it's a slightly wishy-washy term that's thrown around, you know, people, you know, certain diets decreasing inflammation, but I mean, it is definitely a component of most diseases, and you see it in psychiatric disease as well, that if someone's in a very depressed state, you see a high concentration of cortisol in their blood, you see high concentration of certain interleukins and other molecules. But yeah, relating to psilocybin, there isn't that much research, and we're mainly looking at it just mainly out of interest. It's a very exploratory outcome. But another thing we're looking at, and the key thing we're looking at actually in the bloods, which I might not have mentioned, is BDNF, so brain-derived neurotrophic factor. We're looking to see if that is increased, and BDNF is associated with increased neuroplasticity. It's involved in the bridging of connections between neurons, which is the basis of learning, memory, unlearning as well. And yeah, that's essentially, that is probably one of the mechanisms by which we see all of the downstream, you know, more macro level psychological changes from psychedelics. So yeah, to answer that, we're mainly looking at BDNF, and the immune system stuff is just exploratory.
Thank you so much, Sorcha. The next question is for Rayyan. Isn't abusing a substance a behaviour? I mean a complex of chemical dependency and the behaviour of doing the drug. And do you consider the factor of network of people with addiction?
Okay, I think I got the first part of that. Might need a bit of clarity in the second part, but I can answer the first. So, abusing a drug, taking a drug, any behavior that is involving consummation practice is driven by reinforcement learning. And reinforcement learning underlies the kind of appetitive effects of drugs. So when you first take a drug, you have a dopamine surge, and that kind of lays the kind of motivational memory in order to take it again, because you have this kind of surge in neurotransmitters which assign a valence and also a memory to that. Now, in drug abuse or drug addiction, which is the more correct term, that can often become automatic and not actually within the control of individuals. In fact, most people that are addicted to substances say that they don't actually have control over the behavior. They just impulsively or compulsively start taking drugs. And what we're beginning to see is the networks in the brain that are involved in it. And we're actually beginning to understand it's actually quite a biological process. So craving automatically happens, and that craving can kind of override any frontal higher order cognitive systems that are in control of stopping you from doing a behavior. And these very limbic drives essentially take over and cause individuals to take drugs almost responsibly, without any kind of ability to start and stop. So although it is a behavior, it's very much underlied by a neurobiological process involving dysregulation of motivational systems related to reward and frontal systems related to control. And essentially, it's a motivation reward system that wins in addiction. And part of recovery is actually trying to regain that balance or regain control. So it is stemmed in biology, and that's a lot of the work that we do with circuit neuroscience. And then the second part, I think there was a clarification in the chat.
Yeah, I think so.
Of people around the addicted person that, so the network would make him.
I believe this is maybe about social influence of other people that may also be using drugs.
Yeah. So the social influence is very important as well, and that causes individuals to learn certain behaviors and to crave. But essentially, what I'm trying to say is that the biopsychosocial roots of addiction are all present, and these can be peer pressure, these can be having low economic, being a lowly economically, or being living in a deprived area, having low educational attainment, having a family history of addiction, leads certain genetic markers, for example. But all in all, what these contribute to is the dysregulation of this reward pathway, because that's very simply the pathway under which the consuming, satiation, withdrawal, so it's binge intoxication, withdrawal sort of cycle of addiction is maintained in. And that is very much a kind of neurobiological focus. So even that actually seeing individuals that you usually take drugs with can actually incentivize you to take a drug. And this can even happen in healthy individuals. So if you've got a friend of yours that smokes or that you go to the pub with and you see them, you might think, oh, shall we go for a cig, or shall we go get a drink? And that is an example of your craving system, your cue reactivity firing up because you've seen that person, you associate it with that memory, and you want to go do behavior. So the brain kind of model is just a way of trying to characterize why it is that we do certain things. And so that's sort of why we look there. I hope that answered the question.
Thank you very much, Ryan. Yeah, we've got a really lovely question here from Natalie, who says, there's a lot of research to suggest that certain drugs can affect young persons before the age of 25. How are you conducting your studies around this? I assume, Hannah, you might be working with some quite young participants with anorexia. So
I'm actually not.
never mind.
No, it's just I mean, we specifically recruited people who were 21 to 65, and actually the majority of the people that we've recruited are way over kind of the age of 30, which wasn't really what we intended. But I think we have ended up working with an interesting group of people with anorexia that have a really ingrained type of anorexia that is probably quite different to what you would see. Oh, we've lost him. In people
Sorry, I think Ryan just had to go quickly.
Adolescents, but I think we actually specifically chose to recruit people who were over the age of 21, just because of the condition would be more ingrained, and kind of, I suppose, based less on shape and weight than it would be in younger people. But we do usually recruit from the ages of 18 above. I don't know of any trials currently existing that recruit lower than that. I don't know if anybody's trying to do that at the moment. They probably are. I think that's just a safety consideration. I think it is something I think when screening, you do often get the sense that people who are a bit older are maybe more prepared for what this could potentially bring up. It's obviously quite a challenging experience, and maybe for someone that's a bit younger, maybe they would require some more preparation, or they would have more to work with if they were a bit older. But yeah, we only currently recruit over the age of 18, and I think people are thinking about adolescence, and obviously that is I probably wouldn't do it myself, but obviously there'll be experts in the area, and I'm sure that they'll take all the precautions that they need to.
Thank you very much. I was just wondering, Sorcha, if you had anything to add there.
Yeah, we also only recruit people between 21 and 65, and the youngest participant we've had has still been several years older than 21. So we haven't had any super young participants. Most of ours are also around sort of 35, around that kind of zone, 35 to 40. I'm not sure why. But it's we try and recruit people as impartially as possible and balance the gender ratio and everything and balance the age a bit, but it seems to be around that period. Maybe because people who are younger are studying and feel like they have less time to commit and things like that. I'm not sure. But yeah, I personally wouldn't give psychedelics to people under 21 myself. I think the harm prevention side is so important. I think these compounds do open doors for people. And I think people speak about harm prevention from a perspective of, if people are genetically predisposed to psychosis, they're obviously at risk, and you'd never include someone like that or someone who had family members with psychosis in a study with psychedelics. But I think it goes a lot further beyond that. I think, even just, how much neuroplasticity these substances can induce can go various different ways, and if they're supported as they are in our trials, it's nearly always positive. And we haven't had anyone with who's had bad experiences during the psilocybin trip. But yeah, I think when the brain's developing, it's so important to not tug at the rope too much in that sense. But of course, there may be studies in the future that are done with a very specific patient population at a younger age, and the benefits might outweigh the risk or the potential benefits. So yeah.
Thank you very much, both of you. So we'll take a couple more questions. Seeing as this is a student society network related event, we've got two questions here kind of related to. The first one is, What master's degrees would you recommend anyone who wants to get into psychedelic research? And additionally, what work experience could you do before getting your PhD in psychedelics if you're interested in the area?
Um, well, I mean, I suppose I personally went down the route of an undergrad in pharmacology with a year in industry, which I was really lucky to actually do at the centre, and then a master's in neuroscience at Imperial, which again gave me kind of a way into the team. And also alongside that, did quite a bit of interning, so I gave up my free time to help with research where I could. I think um I personally, now looking back, I don't know if I would recommend that people kind of just do degrees just to kind of get into psychedelic research. If you think about maybe what skills you're going to gain from your education, regardless of that, I think the skills that we tend to see in our area that are incredibly valuable, especially when people maybe come in post PhD, they haven't done their PhD in psychedelics, but then they'll join our team at a later date. But their skills are so valuable in terms of kind of neuroimaging, coding, experience with patients. I'd say, I mean, neuroimaging is probably the most important one that we would look for. And we have a lot of people join our team later down the line. Statistics. So if you think more broadly and kind of what could you offer at a later date, actually just working with psychedelics may be less valuable than actually having these really well developed skills that you could offer a team later down the line, because you can learn about psychedelics quite easily from reading research papers, but actually developing skills in neuroimaging or coding or analysis is actually quite a lot of work. So that's probably what I would recommend. Obviously, I think research experience in any area of academia is really important. And if you are kind of lucky enough to be able to afford to do some type of internship, definitely do that. Or if you can do it as part of your degree, maybe, which I was lucky enough to do, or in summer, or if you can even just offer maybe a couple of hours a week to some kind of team to help help with some, I don't know, maybe nothing too intense that you could do alongside your degree. But I think that goes for all areas of academia. I think internships and any kind of academic experience always looks really positive. Sorry, rambling.
Thanks very much.
Yeah, I think those points are really, really important. I think it's ideal to do, I mean, I guess you could enter psychedelic research from many different perspectives. You could, be purely computational, you could have done maths or something before, but I think if you'd want to be doing something like a PhD, running a study and looking at a condition from a neurobiological perspective, like the three of us have, I think doing a life sciences type degree would be ideal, psychology as well. But I would say, as Hannah said, just, while you're at university, just to do as much coding as you can do as much work experience, as much lab stuff, even if it's just quite general molecular lab work that, isn't necessarily even related to neuroscience. I did my undergrad in neuroscience at the University of Manchester, and I remember my first year being more general biomed, but I still loved it anyway. It was very molecular biology, kind of genetics oriented, and then my second year was pure neuroscience, which I loved even more. But I was also lucky enough to do a placement year, and I think that really helps looking back. My placement year was a lot more molecular as well than the work I'm currently doing. It was looking at the epigenetic landscape of schizophrenia in Spain, actually, because I did Spanish as a minor with neuroscience. But yeah, I mean, even though I've ended up working in cognitive neuroscience, and I would say this is more my field, it was invaluable to have that experience and just to, learn that rigor at a fairly young age, and to put in some of that work that can be quite grueling. I think, yeah, you never really regret it. Obviously, you don't want to overdo it and just be in the library all the time. But yeah, I feel grateful to have been able to study the brain in such depth from the age of 18. And I did my master's in cognitive neuroscience, which allowed me to do, some more Python work, to delve into EEG, a bit of fMRI, but not as much. And yeah, that led me to here. But I guess to echo what Hannah said, I think the most important thing to do, especially if you're, going off to uni, is to focus on the skills that you can then apply to something like psychedelic research in the future, rather than thinking, just focusing exclusively on psychedelics. Because if you have a good understanding of pharmacology and the experimental practices adhered to within life sciences, biology research, medical research, you'll easily be able to channel things in that. Well, I mean, I can't say that because it's obviously there aren't that many research groups in the world, but you'll be able to channel those skills towards something very much within this domain when the time's right. So that's definitely probably it's quite vague, circuitous advice, but that's the best advice I can give.
Yeah, thank you very much. Lovely. And we're going to I think we'll do one more question. So, we know that the environment when taking psilocybin is very important for outcome. How would you vary the physical environment for different disorders, i.e. OCD, gambling addiction, and anorexia?
Again, I think this is one of the things where we really like there's different designs that you can have in a specific room. I think even within our team we use different rooms, just not really based on the condition, kind of just what we have available. I think one of the only things that I have maybe picked up on is kind of some of our rooms the way that we decorate them can be quite busy, kind of a lot of patterns, and for some people that's really positive, and during the experience it can kind of guide them and they can fixate on these and they really become a part of what they experience. But actually if somebody has kind of autistic traits, this can become completely overwhelming, and all the different colors and all the different lights and the smells. So I suppose that's something to take into consideration, that maybe with some conditions a more tamed down kind of layout of a room would be more beneficial. But maybe this is something that you would learn from an individual, maybe rather than a specific condition. I don't know if you want to add on, Sorcha.
Yeah, no, I completely agree. Currently, we use just a range of different styles. We have different sites and different rooms that we use. I mean, we run the OCD study from a clinic called Cyprus, which I think I can mention. But yeah, that's what we do our study from, and it's slightly different to other studies because we kind of have a base there and we can keep things in the room, so it's a bit easier for us. But it's quite minimalistic. The dosing room that we use, we just set up quite a naturalistic arrangement of things, some plants, like a green screen at the back, which is just has like leaves and things on it. And we also do have some natural like some photos and stuff, but also some artwork that going back to what Hannah said, there's some participants love it, others find it a bit overwhelming. It's kind of meant to look like fungal spores, so we have sort of dotted golden spores all over the wall, and some participants say it's really nice and they look at it and it's slightly moving, especially because it's a low dose we give them, so it's not like they're having that strong an experience. But others say it's a little bit distracting. But so far no one's really disliked the aesthetics. But I think in the future, I mean, I guess it comes down to the need to better understand different shades of different conditions. And I think, honestly, the DSM-5 criteria, it's important for many things. I don't want to negate the importance of psychiatry in general, the ability for someone to say they have, a condition and get treated. But I think it does eclipse the fact that there are just lots of important features that can vary between conditions. So, for example, as Hannah said, someone might have anorexia and have more autistic traits, and they're obviously going to want a very different setup and sensory experience to someone who doesn't. And with OCD, some of them are extremely high functioning, extremely socially confident and comfortable with us, and they love music and they love art and everything, and they love the whole experience. And others find the artwork a bit unusual, they're socially more sensitive. So many different factors beyond just the aesthetics of the room will need to be researched a bit better. But I think as well, you can't really study everything at the end of the day. So like Hannah also said, it might just be a matter of, we have base props and things that we bring in, like hot water bottles and nice aesthetic paintings. And if participants dislike them, we can just remove them. It might have to come down to that.
Yeah, we also encourage participants to kind of bring a personal item with them into the room, which hopefully makes the environment slightly more homey and slightly more comfortable for them. They're obviously welcome to bring whatever they want if they want to bring a blanket. But I think just having something that they can kind of identify with and is theirs, and it doesn't feel like a completely foreign room, we found often helps as well.
That's a nice idea. We should have done that from the start, but I think it would be too much of a confounder now to introduce it, like a special item. But yeah.
Fantastic. Thank you guys so much. Massive thank you to all our panelists, Sorcha O'Connor, Hannah Douglas, and Rayyan Zafar, although he did have to leave. Yeah, I won't take up too much of your guys' time. Just some quick things to say that there are quite a few drug science events that are coming up. Just to shout out a few that are coming up very quickly. Next Tuesday, David Nutt is coming up to York to discuss what's scarier, drugs or drug policy. We also have next week the UK Patient Conference of Medical Cannabis, and coming up in 3 weeks we have a street drugs discussion, a deep dive into ketamine. Thank you very much for watching. Thank you all so much. Have a lovely evening. Take care.